Assalamu alaikum everyone. I'm Dr. Taimur Khan from West Virginia. I'm currently a clinical assistant faculty in West Virginia University over here and practicing neurology in Charleston Area Medical Center. Today my topic is amyotrophic lateral sclerosis, diagnosis and management. Here I'm going to present a case that I saw during my training and I found it really interesting. So here is the history. So we got 57-year-old white female with a history of coronary disease and high blood pressure. She initially presented with left leg weakness. So she had a fall on December 2013 where she fell on the left side. Then she was treated with IV muscle relaxer for her back muscle pain. Then after that she had progressive difficulty walking. She was initially using one crutch from February 20th, 2014 onwards, and then she had to use two crutches. So she initially saw an orthopedic surgeon in a nearby city who got MRI lumbosacral spine. And then she had another fall on May 5th on the right side. So this was an interesting case, and the reason I'm starting for the MRI brain picture because interestingly, the patient was admitted to the medicine service, and somehow the medicine team ended up in ordering the MRI brain, and neuroradiologist gave some very interesting differential diagnosis for this picture. And let me walk you through some of the other sequences of the MRI brain, but here we can see that there is some increased intensities in the precentral gyrus. This is another better view of better resolution of B0 sequence, and over here we are seeing the arrows have pointed to the increased intensity in the precentral gyrus area on the both sides. So the differential diagnosis that neurology was consulted for, whether it is a Wallerian degeneration or it is hypertrophic liver degeneration, or is it any metabolic disease involving the corticospinal tract, or it is any demyelinating or inflammatory disease. The other question raised was whether it is a brainstem glioma or malignant lymphoma. So, and we already know that sometimes corticospinal tracts may appear more intense on the 3 Tesla MRI scans as well. So let us see some more sequences of this patient. So as we are going through this sequence over here, we are not seeing any increased intensity other than just some periventricular increased signals on the lateral ventricles in the frontal horns. This is ADC sequence, and here we are not seeing any. We used for you looking at the acute stroke pictures. This is flare sequence, and we are not looking at. We are not seeing any kind of a structural abnormality near to the CSF spaces. So this is a post-contrast MRI, and we are not seeing any contrast-enhancing lesions on the scan. And it gives us the clue that the patient was not having any tumors or any highly vascular lesions in the precentral gyrus. So these are some of the imaging studies that they did, CT vasculature of the blood vessels on the neck and head did not show any stenosis or occlusion. The MRI cervical spine without contrast did not show any abnormal signals, and MRI of the lumbosacral spine did not show any abnormal signals. There were a few disc stenosis at cervical 3 and 4 and 5 level, but no abnormal signals, myelopathy indications were seen on the MRI scans. So, I've taken out the slides where I examined the patient by myself for the purposes of the HIPAA and just to make presentation rounded to 30 minutes. Here's the summary of my physical exam. I'm just putting over here the positive findings, that the muscle tone was increased in all extremities. I was seeing fasciculations in both arms. There was weakness both arms and legs, and it was ranging from 4- to 4+ in the arms, and it was ranging from 2 out of 5 on ankle dorsiflexion to almost 4 to 3 out of 5 on the quads. The reflexes were brisk, planters were upgoing, and Hoffman's sign was also present. So we ended up neurology after reviewing the MRI scans and going through the differentials. We wanted to do the EMG nerve conduction studies for this patient. And here are the results of the sensory nerve conduction studies part. This is the left median nerve, and we're seeing that the peak latency is prolonged and the amplitude is abnormal. Certainly the sensory component of this patient, she could be having a carpal tunnel syndrome. And let's look at the other components. The motor nerve conduction studies. If you look, the left median nerve latencies are prolonged, amplitudes are abnormal, velocities are decreased, and the left ulnar latency, amplitude, and velocity is affected. The left peroneal nerve in the legs, the latency and amplitude is affected. And this is the F wave that gives us the idea about the proximal demyelination. And if you look at the left median nerve F wave, it is mildly prolonged. And let's go to the EMG, the needle part of the exam. Here, these are two columns. These columns over here show the spontaneous activity, and over here we are seeing the motor unit action potentials and the recruitment. If you look at the tibialis anterior, peroneus longus, and gastrocnemius, we are seeing fibrillations. These are the signs of denervation. And here we look at we have given here nerve roots levels for these muscles, and the nerve CP over here means common peroneal nerve, and TIB means tibial nerve, and these are the nerve roots. So I'm seeing excuse me, denervation changes in the tibialis anterior and peroneus longus. So if you look at these two muscles over here, I'm seeing S1 common root in both of these muscles. So the peroneus longus is coming from, is part of the myotome from the S1 nerve root, and it is supplied by, if you look at in this particular myotome, there are two muscles, peroneus longus and gastrocnemius, and there are two different nerves. One is common peroneal supplying the peroneus longus, another one is the tibial nerve supplying the gastrocnemius. And over here in these two muscles within supplied by different nerves from the same myotome is showing the denervation changes. And if you look at over here, we are also seeing denervations by the polyphasia of the motor unit action potential and their increased duration. Now let's look at the EMG of the left arm. Over here, the left first dorsal interosseous, that is a muscle of the ulnar nerve with the nerve root of AC8, and abductor pollicis brevis, that is the muscle of the median nerve innervation, and the nerve root is still C8. So with the same dermatome from the C8 nerve root, the two different muscles supplied by two different nerves have denervation changes. So this is a very important point that we have to learn from this EMG, that the denervation changes are seen in the muscles coming from the same myotome supplied by the different nerves. So not all the nerves are involved in the same myotome. And if you look at the right arm EMG nerve conduction studies, the The denervation potentials are seen in the C8 nerve root over here, and over here also we look at the ulnar and median nerve innervations muscles are also affected. Fasciculation is also a marker of denervation, and over here we are not seeing that much of a denervation because there is no polyphagia and there is no increased duration of the motor neuron action potentials. So now this is the looking at the paraspinal muscles, the last part of the EMG, and over here if we look at the lumbar paraspinal muscles is showing one fibrillation. So over here we can make it before we can conclude that if the EMG is involving two different muscles from the same myotome and involving two different nerves, this is very consistent with the diagnosis of motor neuron disease. And the MRI we looked at the beginning, certainly that was showing the origin of the corticospinal tract and precentral gyrus areas, and that's why those increased signals were connoting to the fact that upper motor neurons are involved, and that's what was reflecting in the physical exam as the increased breast reflexes, outgoing planters, and positive Hoffman sign. And over here, the fibrillations we are seeing over here, and other part of the EMG was reflected as fasciculations and the weakness and the atrophy in the muscles of the arms and the legs. So that's why the patient was diagnosed with motor neuron disease, and she was recruited in our multidisciplinary clinic in West Virginia University Hospital. So here's something, let's briefly talk about this was the part of the diagnosis, and here we're going to scan through the management part after a brief introduction to the disease. So it is a neurodegenerative disorder of the undetermined etiology. There are different proposed etiologies that we are going to go through, and affects the motor neurons in the motor cortex, brainstem, and spinal cord. In 1874, the Charcot, Jean-Martin Charcot, gave it a name as amyotrophic lateral sclerosis because it was a combination of the muscular wasting and the gliotic hardening of the corticospinal tracts coming from both upper and lower motor neurons. Here's a famous baseball player from New York in the late 1920s and 1930s, and his name was Lou Gehrig, and he had this disease, and that's why this disease is also known as Lou Gehrig disease. So this brief incidence that it is 1 to 10,000 to 1 in 100,000. The mean age of onset is about 57 years. In age group less than 70 years of age, the male to female ratio is 1.3 to 1.5. For age groups more than 70 years of age, the ratio is close to 1. So the theories of the Als pathogenesis, these are the different theories. Different proposed theories: excitotoxicity, ranging from free radical induced damage to the viral, immune, and hormonal alterations. This is a brief diagram commenting on that the free radicals can affect the neurons, motor neurons over here, and it can cause the damage as well. So here are different upper motor neuron signs and the lower motor neuron lesions from the disease. Here we are seeing that we can see spasticity, increased reflexes, upgoing planters, increased tone, diffuse atrophy of the muscle, large area of the body being involved with upper motor neuron component, and with the lower motor neuron component where they are involved the flaccid paralysis, decreased reflexes, low downgoing planters, decreased tone, fasciculations, atrophy of the muscles, and the small areas of the body is being affected. Presentations and classifications. So there are different variants that we can see. It can be a pure spinal ALS. It can be just involving the lateral corticospinal tract. It can be just a pure lower motor neuron variant. It can be a familial. It can be involving only one arm. It can involve present as a flail arm. It can be hemiplegic, and it can be with dementia, frontotemporal dementia complex. So what is the famous electoral criteria for the diagnosis of the motor neuron disease? It says that it has to be, there should be evidence of the lower motor neuron degeneration by the clinical, neurophysiological, or neuropathological exam. and there should be evidence of the upper motor neuron degeneration by the clinical exam, and there should be a progressive spread of symptoms or signs within the region or to the other regions as determined by the history or examination. There should be absence of electrophysiological and pathologic evidence of the other disease processes that might explain the signs of the lower and upper motor neuron degeneration, and the absence of neuroimaging evidence of the other disease processes that could potentially explain the clinical and electrophysiological signs. So here's the different categories based on the LS Codal criteria. Here are 4 segments that we'll really look at. 4 spinal segments. One is bulbar, one is cervical, other is thoracic and lumbar. If 3 regions are involved, then it is definite ALS. If 2 regions are involved, then it is probable ALS. And if it's one segment is involved, having both upper and motor and lower motor neuron, then it is a possible ALS. The WAGI criteria can allow the electrodiagnostic and clinical criteria to be combined for if the single limb would be abnormal, and it involved the finding of a fasciculation potential in the needle EMG as evidence of the ongoing denervation. So these are the possible differential diagnoses that one should keep in mind and one should rule out when needed. This is a long list, and that certainly should be, one should keep it in mind. So here's the treatment component, and treatment can be certainly a multidisciplinary approach. Over here in the West, we usually have multidisciplinary clinics where the patients are seen by the physical therapist, occupational therapist, neurologist, pulmonary critical care doctors, and the patient is being assessed by a different group of people in the same day, and the appropriate diagnosis, the treatment, and the prognosis plan is laid out. And if the patient needs psychological and spiritual support, is also being arranged during those sessions. So speech therapists are also involved because potential patients can have a speech therapy. Patient may need speech therapy and have speech issues, and certainly in order to address the nutrition component, patients have been given the PEG tubes is installed, and we're going to talk about it briefly. So the medication for the ALS, the only one prescribed medication for the ALS that was approved in December 1995 is riluzole. It slows down the progression of the ALS, and it adds to they say that it kind of delays the progression by a couple of months. The 10% survival benefit, especially in the bulbar onset, and side effects are hepatotoxicity and neutropenia. The liver function and the blood count should be monitored monthly for the first 3 months, then every 3 months thereafter. So respiratory therapy for these patients. Patients with functional vital capacity values ranging from 30% to 50% of the predicted value should be given the non-invasive positive pressure ventilation. And those with the hypoxia and hypercarpia with FVC, less than 30% of the predicted value, long-term invasive ventilation, tracheostomy, and permanent positive pressure ventilation should be given. So here's the device known as diaphragm pacing, and for patients for chronic hypoventilation who use this device, it is installed with the diaphragm. They have a greater survival time, up to 16 months, when compared to patients who use non-invasive ventilation alone. This is 100% survival rate for all patients who had simultaneous feeding tube placement for and the diaphragm pacer at the same time, and it also had improved patients' sleep quality. So for the symptomatic treatment for the mild to moderate dysphasias, diet modifications to a softer diet, and in severe cases, the PEG tube has been placed. For the dysarthria, speech therapists and communication devices are provided. For the drooling, the anticholinergic medications such as scopolamine, one of the anticholinergic components like atropine, Elavil are given. With the refractory cases, the Botox and low radiation therapies have been tried as well. So pseudobulbar effect, and it's very interesting phenomena that it is one of the upper motor neuron effect from the bulbar component that the patients have increased laughing or crying, and for that combination of medicines, dextromethorphan and quinidine that comes with the combination as D-dextra is tried. Terminal care revisiting advanced directives should precede the discussion regarding the hospice and palliative treatment. These are different experimental therapies that have been tried for this disease process. The stem cell transplantation and gene therapy is also one of the most worked on areas because the patient is a strong familial variant of this disease as well. So prognosis of the patient is 3 to 5 years, but survival can be up to 10 years and even beyond, although rare, approximately 10% to 20% has also been reported. The good prognostic factors are non-invasive positive pressure ventilation, the enteral nutrition, the younger age of the onset, limb variance, the baseline functional vital capacity more than 75%. The bad prognostic factors are older age at diagnosis, the bulbar onset, comorbidity with the dementia. As we know that the corticospinal tract starts from the precentral gyrus. Some of the fibers are from the postcentral gyrus area, and also there is a component coming from the temporal lobe as well. So that's why this type of ALS is known to be associated with frontotemporal dementia type. And if that is present, that is certainly a bad prognostic factor for the disease. And if the baseline FVC is less than 75%, then certainly the patient is more prone to the respiratory failure. So these are the take-home messages. First is good clinical exams is certainly the key to diagnosis. In our patient, if she haven't ever given a good thorough exam from the beginning, if somebody had checked fasciculations and good reflexes and planters, then they would be able to formulate the diagnosis even before MRI would have been done. So that's why I would really say that good clinical exam is the key to diagnosis for this disease process, for any neurological disease process. Bilateral hyperintensities along the corticospinal tract on the T2 weighted images and the FLAIR images in the appropriate settings is certainly suggestive of the amyotrophic lateral sclerosis. As we know that with the 3 Tesla MRI, there can be an artificial increase in the intensity. So we have to really look at the kind of MRI machine we are using. And appropriate settings certainly mean that the patient's clinical exam should be also looked at whether it is not any kind of a Wallerian degeneration going on. And motor neuron disease is a myotomal disorder. And as I was explaining it, explained and reiterated this fact during the EMGs that it does not spare any individual nerves in the same myotome. So all the nerve muscles within supplied by different nerves in the same myotome were involved in on this patient's EMG as well. And the classic picture in the ALS would be of a denervation that we saw as a fibrillation and fasciculation potential, the reinnervation, the decreased recruitment and decreased activation. The decreased activation of the motor units and potential is some finding that gives us the clue about the upper motor neuron component of this disease process. And if this picture is seen by different muscles generated by different nerves and myotomes, this is certainly very suggestive of the motor neuron disease. So here's the end to my talk, and if there are any questions, I'll be more than happy to take questions.